Hello and welcome to the channel. My name is Dushan and I'm your osteopath. Today's video will be covering low back pain. The reason I'm doing this video is because I believe you guys need answers and need educating. So many people go on YouTube or go on Google and are looking for answers. In today's topics, we'll be covering the red flags, causes, diagnosis, and the treatment, my treatment approach for low back pain. So we'll get right into it and we're going to start off with the red flags. So question, what are red flags? Red flags are signs and symptoms that we see in patients where we refer straight to the ambulance or straight to the hospital, because if anybody has any of these following symptoms, we can't treat them and you need to be seen as soon as possible. So saddle anesthesia is the loss of sensation. So saddle, think about it when you're saddling, it's loss of sensation in the groin and in the buttocks and around the genital area. So you'll normally feel it or not feel the sensation when you're wiping your bum or any other contact that you would have in that area. And that is an area for concern. Another one, you have urinary incontinence, which is self-explanatory. So you can't control your bowel or bladder movement. So when you want to go pee, you can't pee, and when you don't want to pee, you pee. Next one is neurological deficit. So neurological deficit in low back pain would be you have loss of sensation, you have weakness, you have numbness, you have pain in your legs, or you have difficulty walking. So any sensation that is limiting your function and your movement, because there's weakness or numbness or tingling in both legs, then that comes under red flags. Another one is if you've had any rapid weight loss in the space of like 3 months. Normally family or somebody would have noticed that you've lost quite a lot of weight. This would be accompanied by night sweats. This will also be accompanied by fevers. And yeah, this all comes all under one. These are the predominant signs and symptoms of red flags, which if you came into clinic and I saw you and I asked you these following questions, do you have any of the following? And you said yeah to 1, 2, 3 or more, then I'd be telling you to go to the ambulance and hospital. So now let's go into the causes. So in my clinical experience, around 98% of low back pain causes are all mechanical. So just to save time, what I'm going to do is I'm going to list them and then I'll come back and explain them all. So these are the 4 main mechanical causes that I see in clinic for low back pain. So if I take the first one, for example, talking about lumbar sprain or strain, I'm talking about the muscle fiber that's been stretched or overstrained. It could be either due to injury, so whether it be sports, whether you've been in the gym, whether you've been doing something at home or at work and you hurt yourself, or it could be ligament damage. And ligament damage is harder to achieve. So normally there is more of a force that's caused the issue. For example, like a car accident or falling down the stairs. And these guys here, it's aggravated with movement. And it typically becomes better with rest. But not just any kind of rest, it's active rest. So I still want you to go walk around. I still want you to carry on with your daily activities if you can. And you should be able to manage if it is just a muscle fiber. However, if it is ligament damage and it is very acute and painful at the early stages, you should rest. I'm not in a position to advise painkillers. However, if you do decide to take painkillers, it could help with the early stage progression of rehab. So if you are taking painkillers at the start, it could allow you to move and become more free, which then after a couple of days, you're off the pain meds and you're able to function properly without them and carry on your own rehab without the painkillers. But again, disclaimer, I can't say anything. I can't advise on medication. Discogenic pain and disc herniation. What's the difference? So discogenic pain, it's overstimulation of the pain sensitive nerves within the annulus fibrosus. So here we have the disc. This here is the bulge or the herniation. I don't know if you can see. However, the annulus fibrosus is the content within the disc itself. So this can become sensitive if it's like highly or overstimulated. Disc herniation is here, is where the contents of the disc bulge protrude out and they press on these yellow nerve roots on the spinal nerves. And this would cause, so disc herniations would cause sciatica. Sciatica, if there's any pain going down your leg, it could feel weak, numbness, tingling, shooting, sharp pain. There's many different characteristics that patients describe sciatica. These guys, they're often aggravated with coughing, sneezing, bearing down. A test that we do is called Valsalva. So if it's a positive test, it's simulating coughing. So it just increases the interspinal pressure. So when you go, so the test is carried out like this. So you make a fist and you blow really hard. And that would increase the pressure and cause pain. So examples like the coughing, sneeze, and laughing too hard, etc. Now, facet joint pain is also another common one. Facet joints are these guys on the side of the spine that articulate together. Facet joint pain is typically painful on extension or a bit of rotation. Some of the causes for it is if it's repetitive, overstrenuous activities or from work. So for example, if you're at a warehouse lifting boxes into the van, doing the same motion every day for the last 5-10 years, is going to irritate and stress that joint out. It's going to irritate those ligaments that are supporting it, and it's localized pain, so you'll feel it more in the middle or just slightly off to either side of the spine. Now we come on to sacroiliac joint pain. The sacrum is the base here. This is the coccyx, the tailbone that people say. This is the sacrum, and these guys are the iliums. And then here is the sacroiliac joint. So that area will become painful, and by location, somebody will come and say, oh, I have pain right here. So it'll be low to the spine, and it'll be on either side. So when I was talking about facet joint, people point to just either side of the spine, with these guys being your spinous processes. And when people are talking about sacroiliac joint pain, they'll point down low where the pelvis is, much further away than where the facet joint is. And really bad sacroiliac joint pain can mimic disc herniations because it locks and stiffens the pelvis, and because of that, the muscles around it in the gluteal region will tense up. And what happens commonly is that the piriformis muscle becomes tight and compresses the sciatic nerve. And when that happens, people then start to have elements of sciatica. True sciatica, when it's being compressed from the spinal roots, the sciatica will travel all the way down into the ankle and calf and feet. However, with sacroiliac joint pain, it rarely goes past the knee. So you'll feel it all along the back of your thigh and maybe some elements into your calf, but it will never be all the way down into the ankle and into the foot. That's only if it's true sciatica. So I said 98% of cases are mechanical, and then the other 2% are what we call systemic, and they're quite rare, so we don't want to be naive and like overlook it. It happens, it could definitely happen, but you can pick these things up. So for example, one that always stands out to me is when I picked up somebody with what we call spondyloarthropathy. So these are like, this is just inflammatory spine conditions. So this is normally with like lots of inflammation within the spine. And the number one example is AS, or ankylosing spondylitis. With ankylosing spondylitis, the spine and the ligaments and the tissues along the spine stiffen and they calcify, leaving you with like a bamboo spine that you'll find on an x-ray. You would need to have blood tests done to confirm. And yeah, the main reason as to why I picked up on ankylosing spondylitis was because the limited range of motion. So my patient couldn't turn his head. It was more of like a whole body shifting kind of movement. And I've seen four patients who have ankylosing spondylitis with different, and they're at different stages. So one guy was quite young, another guy was a bit older, and yeah, so it's a mix, and you're at different stages. You can't fix it, it's irreversible, but you're able to manage the condition with the right treatment, with the right approach, exercises, management, nutrition, lifestyle. You can definitely lead a good lifestyle. And then again, with systemic, you can have an infection. So infection of the spine. Infection of the spine. The most common one that comes to mind is osteomyelitis. So where there's infection of the bone and there's swelling within the bone. So there's swelling within your spine and it's not quite nice. These are just the main ones because it's so rare, because it's only 2% that I've seen. These are the ones that I just thought I'd bring to attention, but I will add other possibilities and other causes. We have diagnosis. The main way I come to my diagnosis, where majority of the work is done, is through my case history. Or through just effectively through communication. Where you hear the patient out, where you listen to them, and they'll tell you majority of the answers. Where does it hurt? They'll tell you the location of it, the site of it, the nature of the pain. They'll give you a lot of information if you let them talk and if you probe the right questions out of them. Case history. Then the next one would be the physical assessment. The physical assessment. So this one mainly is about the range of motion, active and passive. So the active and passive movement is seeing what the patient can do by themselves and what they can't do by themselves. So if they can bend forwards, if they can lean back, twist, both sides, side bending. And if they can't, why? What's stopping them? Is it because of pain? Is it because of tightness? Is it because of, I need to find a reason and figure out why they can't do their active movements by themselves. And this is where palpation and my special tests also come into place. So palpation is feeling. I'm feeling their tissues. I'm feeling their joints, how they're moving. Feeling it like with my fingertips and my hand, I can really feel the consistency of the tissue, the fascia, how it's moving well or how not. Also, if I do press in certain areas, they will let me know if there is pain, if there's no pain, if one side is more sore than the other, if I'm setting it, if I'm triggering anything. And similarly with special tests. So special tests for the lower back could be, as I mentioned in the causes of disc bulge, we have Valsalva, then you have your SLRs, you have your slump test, you have Gainsland, Stork, Swift test, loads of different tests to eliminate other causes for lower back pain. So for example, you have SLR for disc, you have slump for disc, then you have your SIFT and Stork test for SIJ, sacroiliac joint pain, then you have Gainsland's for SIJ/hip, and many more which I'll list on as well later on. And lastly, with treatment, what does a treatment with me look like? So it'll be lots of myofascial work. Myofascial work. So with myo, muscle, and then fascia is, because it's so interconnected and intertwined, is I like to work layer by layer, step by step. First you warm up the body and then you get into deep with the muscles, whether you're using hands, percussion gun, rock blading, gua sha, whatever you like to use. That is one of my steps. The other one that I tend to do a lot of is stretching. Stretching, if it's permissible, if the body allows me to, if it is for the right reason, why am I doing it? And another tool in my box is spinal manipulation. So spinal manipulation is very effective in the short term to relieve pain and increase range of motion. But the main thing for me is, I don't care if this is short term, but if I combine all these steps together, then it'll provide longer lasting effects, which is why I do 1 hour treatments and not just 20 minutes here, 30 minutes there, see me later. I combine loads of different steps so that the body can heal by itself. And the last one is what I'm doing now, is education, exercise advice. Because at the end of the day, my goal is that you don't come back to me. I want to help you so you're pain-free and that you go out there and live your life. So with education and exercise advice, is my main goal is to help you become as independent as you possibly can be. And that's the end of the video. I want to say thank you to everyone that's watched all the way to the end. Hope you guys have found this very useful. Please comment down below any other topics that you would want me to go through. Please mention anything that I may have missed, because I am human. And yeah, like and subscribe, and I'll see you for the next video.